Namaskar and welcome to this series of videos on understanding knee problems. We are going to show you and create around 3 to 4 videos of knee joint problems, how to understand, how to examine the knee joint, how to understand a knee joint MRI, and how and what can be taken into consideration when diagnosing a knee problem. So such 3 or 4 videos will be kept in sequence, and today our first video is going to be on understanding a knee problem by history taking. When the patient comes to you in your clinic, how do you understand what the patient has a problem of? What is the diagnosis? Only by history taking. It has been my experience over the last 32 years that seeing the patient, talking to the patient can give you a 90 to 95% idea of what problem the patient is facing. I have also seen a lot of patients coming with huge bulks of files, reports, investigations, MRIs, X-rays, etc. without diagnosis, without understanding what they have, and just seeing them walk down from my entry in my clinic. I have kept around a space of around 10 feet from the entry door to my table to the examination couch. So when I am standing there, I practice standing in my clinic. So when I am standing there and seeing the patient come in, the walk, the limp or the pain that the patient has gives me an idea of what the problem is. One, we are understanding problems in the knee joint, but the gait can tell you whether the patient has a problem in the knee or the hip. The gait can tell you whether the patient has a problem in the knee or whether there is some other problem which is mimicking a knee problem. And one of the commonest problems which mimic a knee problem is Parkinsonism in old age. See, I do a lot of replacements. So a lot of old people come to me and I have seen that Parkinsonism mimics a lot of problems of the knee, and just the walking, the face of the patient can just give us an idea that, oh, I think we are dealing with a neurological problem and not a knee joint problem. Another thing is, if the patient has a foot drop, either because of knee injury or for some other reason or a spinal problem, and he has a very typical gait of the foot drop, then also you have some idea of what's going on. Let's say the patient has a ligament injury, old ligament injury, and he comes walking and has a foot drop. You have a basic idea possibly that the patient could have a PCL with a PLC or a lateral opening injury which has led to the damage to the lateral popliteal nerve. That's why the patient has a foot drop. So that seeing the patient, that look on the gait of the patient or the entry of the patient towards the sitting table or the examination couch gives us a very good basic idea of what the patient could have. The next step in understanding what the patient has is history taking. So once the patient is seated, I have again seen a lot of times that the patient starts with, sir, I have got an MRI and I have a problem. So I tell them, please keep everything on the table. Don't tell me anything about your MRI or whom you have shown to or what the other doctor has told you, because many of the patients will directly tell you their diagnosis. Sir, I had been to this doctor and he has told me that you have a ligament injury. And I said, please don't make me biased. And I tell them very clearly that sometimes if you tell me what you have, I may get biased and I may make a mistake. The doctor may be absolutely right, but still I need my understanding of their problem. So I tell them, please don't tell me your diagnosis, just tell me what you have. So I tell them to put all their MRIs, reports, everything in bags and on the table. Don't show me anything, don't tell me what you think or the other doctor think you have. And let's start from the beginning. So I ask them, okay, tell me what happened. So that's the first question that you will tell is what happened. So he says, sir, I had a history of fall. I fell down. So I ask them, okay, the next question is when. So they will say, sir, it is around 2 months that I fell down and I had problem in my knee. Then I ask them, how did you fall down? Now it's very important to understand the mode of injury. How? So see, let's say a simple patient, a simple diagnosis of an anterior cruciate ligament injury. Now there are n number of ways that the patient can fall. Let's say majority of our cases come because of vehicular accidents. So let's say the patient has fallen down from a motorcycle or a scooter. In our country, majority of ligament injuries are because of two-wheeler accidents. Now that injury, if the patient says I have had a vehicle accident, the back of your mind should start analyzing that that injury is major, it's not minor. There is a difference between a man walking, tripping on something on the floor, falling down and having a ligament injury, and a man falling from a motorcycle and having a ligament injury. Because in the subsequent or the latter cases when there is a vehicular injury, there has to be associated bony injuries, there has to be associated maybe more than one ligament injury, there has to be associated more swelling, more pain and more stiffness or more damage to the knee, more hemarthrosis in the knee as compared to a man just tripping and falling, or missing a step and falling, or slipping in a puddle of water and falling. Or else there is again a difference that a man falls from either they say, sir, I fell into a pit, or I fell into a deep pit, or I was playing cricket or football or hockey and then I fell down. Those injuries are markedly more severe because the person or the patient is running in speed and then it happens. So it's a major injury as compared to what he has with just missing a step, or in our Gujarat doing Garba and then having this injury. So mode of injury can give you an idea of same diagnosis, but the severity of injury changes. And if a person, let's say, has minor injury and leading to ACL, maybe I can operate on him by 15-20 days because the knee movement comes quickly, patient is comfortable, there is no much swelling, and I can operate by 15-20 days. But in a vehicular accident, let's say, and he has marked bone edema, I would better wait for more than a month or 6 weeks for everything to subside and cool down and the patient getting a good range of motion, and then only operating. So it's not only the diagnosis, but understanding when to do, what to do, how to do subsequently. This history will give you a very good idea. Now, as I said, when. So when also gives us an idea whether it's a chronic injury, fresh injury, whether we need to do some pre-operative physiotherapy in the patient before deciding surgery, whether the patient has some associated injuries also if it's a major injury, and local abrasions or not. So when again becomes very important as to this. Now one very small and very important point in when. Many of the patients do tell me, sir, I fell down 2 months ago and it was a very minor injury, I was just walking and I fell down. Then I start thinking that you can't get a problem that patient has shown 10 doctors and has come to me as an 11th doctor with such a minor injury. He has to have something else going on behind leading to an injury which was neglected and which has led to a problem because of this minor injury again. So when that spark comes and when that experience comes, you will realize that there is something hidden in the past that the patient either has ignorant or has forgotten, or maybe he is hiding, just trying to test you, because I have seen many patients bringing out an MRI once I tell them that I think this is got. So that also happens quite a lot. So either that, or they think it is not important for you to know that he had some injury maybe 2 years ago or 4 years ago. So please be very careful when you take history from the patient, that please ask, was this the first time that this injury has happened? And around 20% of cases, you do get a old history or a past history of injury which was more significant than this injury, and that injury caused something that patient had neglected, and then it has got aggravated because of a minor injury in the recent times. So that also helps you understand the dynamics or the mechanodynamics of the injury over a period of time. So please be very careful in understanding the duration of injury. Another thing that I want to clarify today and specify very clearly is whether the patient has got injury or not. You see, when you see a knee joint, when you take history, when you try to understand the problem that the patient has come to you for a knee joint, please demarcate into two close divisions. See, I am not telling you as far as how exams are conducted. This is not a how to give an MS Ortho exam video. No. This is a practical video which you are going to do in your own clinic. Very short time, you have maybe 5 minutes in understanding, 5 minutes of examination, maybe by 15 minutes you want the patient to be gone because you have 20 more patients waiting outside and you have 2 surgeries waiting for you. That's what usually happens in the OPD. So you have to, all my videos are going to be practical videos, doing what you can do in a very short period of time, and don't miss anything. So again we come to the point, injury, whether it is genuinely an injury which has caused this or not. A patient has misunderstood that patient has an injury and it is something else. So demarcate the problems of the knee joint in your mind, go this again and again and never make a mistake, into just 2 parts, traumatic and non-traumatic. injury or no injury. Once you clarify this, half the diagnosis will disappear, and you have to then the differential diagnosis contracts, and you have very few lists as a differential diagnosis with you, and you tend to make less mistakes in understanding the problem. So many times the patient, sir, I had a history, and the history is very vague. The patient is not clear about what mode of injury. Yes, I had banged my knee on the corner of the table or the corner of the bed, or I had missed a step and I had this, that, and patient is very vague. He is not specific. Okay, what was the time? Oh, maybe 2 months, 4 months. He is not again sure. And that time, so I tell them, okay, you were injured, that's what you feel, fine. Did you have pain then at the time of that injury? The patient will say, no, it was maybe for a day or two, I was fine, there was nothing much. Okay, so now this major pain or the severe pain that you have, how much time has passed post the injury that you have this pain? Oh sir, maybe 4 months, maybe 5 months. Now then you should start understanding that any major injury then would give pain for half a day or 1 day, and then for 4 months there is no pain. There is no such injury that can occur to a patient. So injuries by their own nature will have maximum pain when they are injured on the next day and the subsequent day. So the maximum pain lasts for more than 24 to 48 hours. And then the patient pain will start decreasing, but gradually, it not disappear in 1 day or 2 days, and gradually decrease, and the patient will say, yes, I had to go to a doctor, I had to take treatment, maybe I had to get a brace or maybe a patta or something, and I had to miss my job or my work for 2 or 3 days, or I had to take medicine for 10-15 days. Then you understand that it was a major injury, and possibly that injury was the cause of this problem. But if the patient is vague, maybe he had taken a medicine for a day and then subsequently the patient was okay, then please understand that that injury is not significant, and that injury is not the cause of this problem that the patient has. And then subconsciously try to realize and understand the problem of the patient as a non-traumatic patient or a non-traumatic problem of the knee joint. So let us now help you to decide 2 different factors. Fine, as I said, traumatic and non-traumatic. We as orthopedic surgeons understand trauma so very well, but when it comes to non-traumatic, cold orthopedics, we are usually stumped, and we make a lot of mistakes in understanding non-traumatic problems and understanding and treating non-traumatic problems, cold orthopedics. We are afraid. Many of young fellows that I get are afraid to understand or even put a diagnosis of something which is non-traumatic. So traumatic, fine. A patient has injury. What can be the thing? It can be a fracture, it can be a ligament injury, 1 ligament, 2 ligaments, 3 ligaments, it can be a patellar subluxation or dislocation, retinacular tear, MPFL tear. Fine, there are a limited number of things that can occur in a knee joint. But when it comes to non-trauma or cold, then what? So my advice is, first see the age of the patient. See, if it is a younger patient, don't suspect osteoarthritis as a first diagnosis, but inflammatory arthritis or enthesopathies, or let us say fibrositis, let's say chondromalacia patella as a early diagnosis in cases, or paccensorant bursitis in females in early cases. So those things should come first in our mind when such things occur. Then again, there are a lot of other problems which we miss in the early cases, and we focus on the trauma or let's say a pseudo history of trauma and miss out on the cold orthopedics. So keep things in mind. Make a list of what? Neoplastic. So we start with inflammatory, neoplastic, let's say enthesopathies or fibrositis, and we keep this list, maybe infective, and you keep these points listed, keep them close to your, either if you are working on a computer or you are writing, then keep it very close to where you are keeping your writing pad and writing. So when understanding or writing down the history of the patient, and one more small point that I'll add here, just talk to the patient, look the patient in the eye, understand what the patient is trying to tell you, and then once there is a gap in what he or she is telling you, write down that point immediately, because sometimes it happens that you have taken the history, you go and examine the patient, you come back, you forget, because there are so many number of patients you have been seeing, and this tired brain may forget to 1 or 2 important points which you have taken in the history. So just point 1, 2, 3 in the paper. This is the duration, query injury, or whether it is clear injury, this is happened, this what happened, while there is a gap. Or what happens is, I tell the patient, now you please go and sit or climb on the examination couch. So while the patient is doing that, you can write these points and then go and examine the patient. Another small thing is, Don't sit on your chair and tell the patient to sit on the chair opposite you and examine the knee just sitting like that. I am going to tell this point in the next video on examination of the knee, but even this I'll tell you now. The patient has to be taken on the examination couch, the knee has to be exposed and possibly both the knees, and then you do the next step. And that gap that you have will help you write down the points so that you don't, because sometimes when you come, or maybe you send the patient for an MRI and the patient comes the next day with the MRI and you have forgotten what the patient has. And if everything is written, everything will come like a flashback. Then you don't tend to forget. So write down the points only even before when you send the patient for an MRI or an X-ray or anything like that. So that is one more thing. Now another misconceptions that the patient comes to you with, I would really like to clarify this because I have been dealing with the knee joint quite regularly. And initially I was very afraid of knee joint. I never realized sometimes patient, in early 90s, in 1991 and in 85 to 90 time when I was a resident, knee joint was a mystery. We never knew what was going on. We were afraid of putting a diagnosis in a knee joint. It was a very big doubt as to what the patient has, because we didn't have any, common investigations that you have now. No MRI, no CT scan, a very basic X-ray, no understanding of weight-bearing X-rays, very few views that were understood even in a routine simple X-ray. Stress X-rays came very subsequently. Only when ligament injuries got being understood and ligament injuries got being treated commonly, that people started understanding that varus, valgus stress X-rays, anterior posterior stress X-rays, and even those things were not there. Digital X-rays were not there. The X-rays that we took in setups were very basic, ill visualized, and without any understanding of what we were doing, because the technician would be taking the X-ray. The doctors would never get involved. Now I have seen doctors and orthopedic surgeons getting involved in the process of taking X-ray. They are training their technicians, or maybe they are going themselves into that X-ray room and being there and taking the X-ray. So things have changed a lot over a period of time, and that's why the diagnosis and understanding of knee problems has also changed a lot. So let's understand a few misconceptions, and you will come across quite a lot in your practice. The patient will come and tell you that I had gone to this doctor, and the doctor told me that you have water in your knee joint. Pani bhar gaya hai. In Gujarati, pani bhare gayu chhe. In English, it is there is water in the joint. Now they said, you treat that I have got water in the joint. Mere jod mein pani bhar gaya hai. So please treat it. So you understand and you don't fall into that trap. I have seen with full let us say request of being very humble and down to earth, even few specialists telling the patient you have water in your joint, but they don't tell them the diagnosis. Maybe they didn't understand it, or maybe they didn't want to tell the patient, okay, I have a doubt, I have 2-3 things in my mind and I am putting this so that patient has a basic understanding, and then I'll come back to the proper diagnosis when I am there. It is possible and it can happen, fine. It happens with us also, fine, no problem. But then I would request that you do not fall into the trap of understanding water in the joint. Why? Because we treat the cause. So I tell my patients, I understand you have swelling in the joint, there is some fluid in the joint, but we are not treating the fluid in the joint, we are treating the cause of the fluid in the joint. The fluid is not the problem, fluid is the effect, not the cause. So the patient has to be made very clear during the first visit, or even while history taking if he comes out, because the patient will say, sir, I have got this fluid in my joint. There is the history that they will tell you. So you have to come back, you have to be very clear what the patient is telling you, and tell the patient that fluid is a symptom, it is an effect, it is not the cause of the problem. Let me find the cause of the problem. If I treat the cause of the problem, the fluid will go away. So that is number one. Another misconception is the history of locking. Now there is a difference what all history books that we do, examination, history taking and examination books have told us that there is a difference between what is locking and pseudo locking. So the patient may have some pain and that causes decrease in the movement of the joint, and patient say, I get my knee gets locked. So that is pseudo locking because of the pain that is happening. And a genuine locking, which occurs either because of a trapped meniscus or a trapped loose body, will be that the patient is in flexion and the knee is locked and patient is not able to extend the knee. If the knee is straight, extended, and patient is not going to bend it, more commonly than not, it is something related to the painful inhibition of movement. But a real locking occurs usually in 10 to 20 degrees of flexion or more, and it is only during the moment of flexion extension that the knee gets locked and the patient is unable to extend. That is a true locking. And that usually commonly occurs because of either a meniscal tear locking down or a bucket handle tear or a loose body. So please differentiate between the history of a locking and a pseudo locking. Ask the patient, किस position में, what position is the knee in for when it got locked, how did it happen, what were you doing when it happened, then you understand the difference between these two. Another misconception is the giving way, or I am not able, I get, my knee gives way. Now, 2 or 3 things are commonly involved in a giving way sensation. First commonly is an anterior cruciate ligament injury. A PCL, a posterior cruciate, will usually not give a history of giving way or falling down. It's only commonly in ACL, but again a very prominent giving way. I fell down, I got up and immediately fell down, my everything gave way, everything, I just fell down. So please understand that is commonly MCL with either ACL or something. A torn medial collateral ligament will give a very high sense of instability even as compared to a single ACL injury. So that should be in the back of your mind. So in examination, don't forget to do a valgus opening test. So number 1. Number 2 is the giving way sensation. So the giving way sensation, while it can also occur because of a patellar subluxation. So if the patella subluxates, but usually that giving way happens when the knee is flexed or semi-flexed. So while getting down the stairs, while getting up from a sitting position or a ground position, while walking and there is some bending, trying to bend to do something and there is a giving way, usually that will happen in a patellar subluxation. In a normal ligament injury like an anterior cruciate ligament, the giving way will happen when there is a turning or a twisting that happens. So when the patient is turning, getting down the stairs, trying to put a brake, I was going and I tried to turn, I tried to stop myself and I had a giving way sensation. So that usually occurs in a ligament. A patient sometimes is fine, has an injury and continues his sports. Maybe next day or maybe after a week he goes back to his sports, and then again the patient will have that injury that I was running, trying to turn, either while playing football or cricket, I was trying to take a run and turning back from the crease to take the second run and I had this. A bowler having had this injury, going back to bowl with the torn ligament, when he is trying to bowl and complete his bowling, when that knee lands and he will have that sensation of giving way. So that's usually because of anterior cruciate ligament injury. So even that giving way sensation has to be categorized in your mind when you are doing this. That will help you to understand whether the examination that you have done, does it correlate with what the history and what understanding that you had, and then you correlate your examination and history with your MRI findings and MRI examination, and then come to a diagnosis. So let's come to a final part of this video, that is misconceptions. Misconceptions that the patient has for his or her own problems, and misconceptions that we have when we are seeing the patient. Number 1, as I said before, the patient will come and tell you, usually the patient will tell you the diagnosis. Sir, I have this. So please tell the patient that don't tell me the diagnosis, please tell me what you have. What is the problem? Is it pain or swelling or giving, whatever. Please tell me what you have. Don't tell me the diagnosis. Be very clear, be very specific so that you don't get biased. Number 2, common misunderstanding that a patient has is, there is fluid in my joint. मेरे पैर में पानी भर गया है. In Gujarati we say, मारा पग में पानी भराई गયું છે. There is water or fluid in my joint. Either the patient has said, I have this problem, or some doctor has told the patient that you have fluid in your joint and will treat that fluid. Some bone setter has told the patient, oh, you have fluid in your joint, we'll treat the fluid, we'll aspirate, we'll do this, that, we'll tie bandages. There's so many things that are being done these days. So be very clear, tell the patient, yes, you have a problem, you have this, there is swelling in your joint, there is fluid in your joint, but that fluid is not the cause of the problem. It is only a symptom and only the effect of the main cause of your problem. So our aim as doctors and as your treating specialist is to find the cause of the problem. So once we treat the cause of your problem, this effect will go away. So let me see you, let me talk to you, let me understand your problem, let me see your MRIs, let me come to a diagnosis, and we are sure that once we treat you properly, your fluid will go away. Another misconception is, as I said, giving way or falling down, and this can happen to patients in different manners, and different injuries can lead to different sorts of giving way. The biggest fear or the biggest giving way sensation comes due to a MCL injury, a medial collateral ligament injury. It is not ACL or PCL which gives rise to this, it is the MCL injury associated with any other injury which gives rise to a very significant giving way sensation of the patient, and the patient falls down. Many of these patients just fall down because they are not able to even bear a normal weight bearing on a single leg when such an injury occurs. Another giving way sensation comes in a single or a simple ACL tear injury or ACL injuries when there is a twisting or a cutting movement done by the patient. Now, ACL tear giving way sensation, not very significant, but it is, I think, next in the category of severity in a patient. So that will happen usually when they are going downstairs, trying to take a turn suddenly, or going back to sports and trying to take a run in a cricket, or if it is a bowler, then ending this bowling with this leg landing. Let's say it is on this leg and the leg landing, and then this happening, and or else it can happen while walking on uneven ground. So that is what happens. A PCL, isolated PCL injury will usually not give rise to a sensation of giving way. There will be knee pain or anterior knee pain in a PCL injury and a very mild sensation of I am not very comfortable with my knee. Another thing is a giving way sensation can occur in a patellar injury or a patellar subluxation, but that occurs only when there is knee flexion. It will not occur in an extended knee. So while the patient is climbing stairs, going down the stairs, or patient is trying to squat or going down on the ground, that this subluxation of patella will occur or happen, and the patient will get a sensation of giving way. So be very clear when the giving way sensation occurs. And lastly is the locking and pseudo locking. Now patient will give you a history that I have this locking knee, or my knee locks or my knee fixes in some position, or my leg gets locked up. Now there is a difference between locking and pseudo locking. See, severe pain can give you a tight knee which is not moving, and the patient may think it is locking, but it is pseudo locking. So usually such pseudo locking occurs in extension, and there is pain in extension or there is fixation in extension, the patient is not able to bend the knee. That usually occurs because of pseudo locking. Proper locking, which occurs because of two very common reasons, is meniscal tear, a bucket handle, or a loose body getting locked. Such cases, there is some flexion of the knee, and while extending in a position of flexion, the knee gets locked. So the knee is locked in a position of flexion and patient is not able to extend fully. That is a usual picture of a true locking. So please differentiate between this pseudo locking and true locking. Another misconception is that the files or the investigations that the patient have, and you get busy in seeing the investigations and do not depend on your examination. Once you get biased, your examination also gets biased. So my final request to you is talk to the patient, come to some conclusion only while history taking, then examine the patient, come to another conclusion while doing that examination. So by the end of that, you are around 70-80% sure of what the patient has. Then come to your investigations. If you not get the investigations what you want a sonography, or you want a CT scan, or you want an MRI, or you want blood and urine investigations. Finalize that, get it done from the patient. Then when they come back, look at that, and then you can come to a final diagnosis. Thank you.